Hello, I'm Lucy Mailing and I'm an ST7 in trauma and orthopedics. Compartment syndrome. What is compartment syndrome? I define it in 3 parts. Number 1, increased pressure in the osteofascial compartments. 2, which exceeds the perfusion pressure. 3, and leads to tissue ischemia and necrosis. So what is an osteofascial compartment? Well, it comprises skeletal muscles and sometimes bone, which are surrounded by a fibrous, non-stretchy envelope of tissue, the fascia. All skeletal muscles are surrounded by fascia. So in theory, any skeletal muscle can develop compartment syndrome. This diagram shows an axial slice through the leg, which has 4 color-coded separate compartments. So let's break it down. What causes increased pressure within a compartment? It could be external pressure, such as a tight plaster cast, or it could be internal, and causes of swelling such as fracture, hematoma, crush injury, or a long lie, burns, or even a reperfusion injury can increase pressure within a compartment. In a normal compartment, the pressure should be almost 0, meaning there is very little resistance to arterial inflow or venous outflow. If the pressure continually increases, eventually it will exceed the venous blood pressure. And when this happens, veins collapse and no venous outflow occurs. So what happens if there's continued inflow but obstructed outflow? The pressure goes up again, and there is congestion at the capillary level. And eventually, this pressure restricts the inflow of blood. It's a progressive problem which causes tissue ischemia and cell death, which itself causes swelling, which further increases the pressure. And so you can see why this condition is referred to as a vicious cycle. So how does it present? As with all clinical emergencies, you can guarantee that this will happen in the middle of the night whilst you're on shift. And actually, this is often the case. Patients fall over, they sustain their fractures by day, they spend a few hours in the A&E waiting room with the limb dangling down, swelling nicely. And several hours down the line, the swelling is such and the pressure is such that they have developed compartment syndrome. Another reason for this happening by night is that when we're asleep, the blood pressure is lower. And so the threshold for jeopardizing the blood flow is also lower. You may have heard of the 6 Ps. All of these stand for pain. A patient without pain does not have compartment syndrome, unless their entire limb is dead and then you've missed the boat anyway. And you can often diagnose compartment syndrome using your highly scientific end of the bedogram. Mrs. Left, who is preoccupied with her crossword puzzle, does not have it. Actually, Mrs. Wright doesn't either. She's in labour. But this is how I want you to remember it. It's a pain that is so severe that the patient could well be in labour. What are the signs of compartment syndrome? The patient will be exhibiting a pain response with a tachypnea and a tachycardia. When you examine the limb, it will feel solid and woody rather than squishy like normal muscle. If you stretch a muscle from the affected compartment, You stretch the compartment, reducing the space within and further increasing the pressure. So pain on passive stretch causes the patient severe pain. If the limb has paresthesias, the blood supply to the nerves is compromised. If the limb is pulseless, there is no arterial inflow to that vessel, and this only occurs very late in the process. So do not be reassured by the presence of normal sensation or by the presence of a pulse. What investigation is this? This is intracompartmental pressure monitoring. Is it helpful? No, not if you have a conscious patient who's in 10 out of 10 pain, who's got a tense, firm compartment that is painful on passive stretch. You've already diagnosed compartment syndrome in this case, and there's no need to delay treatment whilst you rummage around the hospital looking for one of these contraptions. I have never successfully found one in the hospitals I've worked at. However, compartment pressure monitoring may be helpful in certain scenarios. Can you think of any? It can be useful in an intubated patient, for example, on ITU. This patient can't tell you if they're in pain. Remember I said that the normal pressure within a compartment should be almost zero. An absolute pressure isn't always particularly helpful, but an upward trend should certainly stir up some worry. Some say that an absolute pressure of greater than 40 millimeters of mercury is in keeping with compartment syndrome. But work published by McQueen suggests that the delta pressure is more important. The delta pressure is the difference between the diastolic blood pressure and the intracompartmental pressure. A delta P of less than 30 should prompt treatment for compartment syndrome. In other words, the lower the difference between the diastolic blood pressure and the compartment pressure, then the higher the chances of compartment syndrome. So how do we treat it? 2 words: emergent fasciotomies. Emergent meaning knife to skin within 1 hour of the decision, but ideally sooner. Fasciotomies. We decompress the affected compartment by carefully cutting through the entire length of that fascial envelope, but not the underlying muscle. It is essential to cut the whole length of the fascia because any remaining tight bands will continue to have a tourniquet effect and the compartment syndrome will persist. Because compartment syndrome in one compartment can precipitate the same in adjacent compartments, the standard treatment is to decompress all of the compartments within that particular zone of the body. In the leg, as we saw earlier, there are 4. We can access the anterior and lateral compartments via a longitudinal incision between the tibial crest and the fibula. The calf contains 2 compartments, the deep and superficial posterior. And these can be accessed via a longitudinal incision just medial to the medial border of the tibia. After decompressing the compartments, we wouldn't want to reinstigate the compartment syndrome. So we leave the fascia totally open, and this doesn't have any long-term consequence. We also leave the skin open, again, to avoid creating any compression. Once the tissue has settled, usually a couple of days later, these wounds can either be closed primarily or, if there is still too much tension, skin grafts can be used. The consequence of compartment syndrome is potentially severe. Patients can develop Volkmann ischemic contracture, as seen here on the right. Rhabdomyolysis from the breakdown products of cell necrosis, which can cause an acute kidney injury. Amputation, if the tissue necrosis is severe enough to render the limb useless, or if in the acute setting, the limb poses a risk to life by the above mechanisms, then amputation may be indicated. There are guidelines for most important orthopedic conditions, and we call these BOAST, British Orthopaedic Association Standards for Trauma. You can easily find these online, and they will be helpful should you encounter a suspected compartment syndrome patient. To conclude, compartment syndrome is a clinical emergency, the features of which are increased pressure within osteofascial compartments, which exceeds the perfusion pressure, leading to cellular ischemia and necrosis. Treatment is surgical with emergent fasciotomies. Thank you.